Maintenance treatment with Rucaparib in the platinum-sensitive recurrent setting, we really focus on data from Ariel 3. As we discussed, Ariel 3 enrolled 564 patients in total. It was a randomized, double-blind, placebo-controlled trial that looked to evaluate the efficacy of Rucaparib as a maintenance strategy in patients who had at least 2 prior lines of platinum-based therapy and who had a complete or partial response to the penultimate platinum-based regimen. And what we saw with incorporation of Rucaparib as a maintenance strategy was a significant improvement in the median progression-free survival. And in the cohorts of patients enrolled on this study, the median PFS in the Rucaparib arm was 16.6 months versus 5.4 months in the BRCA mutated population, and it was 13.6 months versus 5.4 months in the LOH high, again with a cutoff of 16%. Both of these significantly better in the treatment arm versus the placebo, and even in the patient population that was the intent to treat patient population, lumping in all patients enrolled, including LOH low, it was 10.8 months versus 5.4 months. So what we see from Ariel 3 is that we have a meaningful improvement in the median progression-free survival with a maintenance strategy, with no significant decrement in the quality of life, speaking to the safety of Rucaparib and the tolerability. The treatment-related side effects are a reality for our patients on maintenance treatment, and it's our obligation, again, to be honest, to educate them about what treatment-related side effects they may experience, and to be proactive about mitigation strategies, because ultimately, our goal is to keep patients on treatment because we believe that this treatment is beneficial at preserving a remission. In treating patients with PARP inhibitors, many of the trials that were designed to evaluate efficacy of Rucaparib had essentially endpoints that were placed for the duration of PARP therapy that were fairly subjective or arbitrary, because we want to balance efficacy versus potential toxicity or adverse event side effects from the drug regimens. In clinical practice, when we treat with a PARP inhibitor like Rucaparib in the recurrent setting, we treat patients until they have unacceptable toxicity or side effects from treatment, or conversely, if they have disease progression. So as long as patients are tolerating treatment, they remain on therapy and in remission, they could be continued on their PARP inhibitor. A couple of the clinical trials that were performed would end treatment at 2 years if a patient remained in complete response. But again, these are fairly subjective designs for these trials, for these endpoints, and in clinical practice, patients can stay on a maintenance PARP inhibitor for as long as they derive benefit.